All right, we're back in Austin, Texas at the annual meeting of women's cancer at SGO, and this is Word on Cancer. I'm here with Dr. Miller, and he is just finished a presentation just literally moments ago. And can you tell us first your name and where you're from and the name of your presentation?
It's David Miller. I'm from the University of Texas Southwestern Medical Center in Dallas, here in Texas, and I was presenting on behalf of the Gynecologic Oncology Group the results of our Study 209, which was a randomized trial comparing cisplatin, doxorubicin, and paclitaxel versus carboplatin and paclitaxel for patients with advanced endometrial cancer.
Describe a little bit what a phase 3 trial is and what came to bringing this to a phase 3 trial and the presenting of the statistics today.
Well, phase 3 trial is when we're trying to develop the best possible regimen. And the only way we can do that is we take essentially our 2, sometimes 3 best candidates, and we put them head to head. We actually have to treat patients. The patients understand that they're going to help answer this question. We think each of those treatments are likely pretty good, but if we're going to advance, we have to know the best. And so that's why we do what's called a randomized phase 3 trial. That way the regimen is picked by a computer. The patient agrees to accept whatever regimen they get. And then we pay attention to make sure that the population's balanced, that the age is the same in both groups and various important prognostic parameters are the same, so that we know, so we look for what we call balance, so that any difference we see we can attribute to the differences in the treatment as opposed to differences in the patient population.
And what is the standard of care to date, and how long has that been the standard of care?
Well, we have just hopefully defined the standard of care because it's been evolving. We had the 3-drug regimen, the cisplatin, doxorubicin, and paclitaxel, which in our previous randomized trials had produced the best survival advantage. This is a difficult regimen to give. It takes 2 days. It has a high toxicity associated with it. And so several years ago, we asked the question, could we use a simpler regimen, the carboplatin and paclitaxel? Would that regimen be as good as the 3-drug regimen, but you still get the good results that we need to have for our patients? So the standard of care is evolving. Hopefully this can reassure patients that carboplatin and paclitaxel is good therapy.
Some of your objectives were obviously quantifying progression-free survival and overall survival. When you looked at that data between the 2 arms of the study, what did you find?
Well, for progression-free survival, if you look at what we call median progression-free survival, for both the 2-drug regimen and the 3-drug regimen, they were the same, 14 months. So they were not significantly different. For overall survival, there was, that was 38 months for the 3-drug regimen and 32 months for the 2-drug regimen, but those survival curves tend to come together. And so when we look at this statistically, that apparent advantage could be due to chance. So that's something that we will follow along. But as I mentioned in the question and answer session, the clinician's guide to statistics is to stick your thumb on the survival curve, and if you can fit your thumb in between the 2 curves, then you probably have something there. For us, there wasn't much space between those 2 survival curves.
Talking about toxicity between the 2, what did you find was the better, better treatment for the patient and in terms of toxicity?
Well, particularly for long-term toxicity, we're worried about peripheral neuropathy or neurologic toxicity because that can be pretty disabling for patients, make it difficult to write, do fine motor movements, makes walking more difficult, particularly for elderly patients. And so that level of neuropathy was less in the 2-drug carboplatin and paclitaxel regimen.
For the women that are fighting with recurrent or metastasized late-stage endometrial carcinomas, what does this new data bring to their treatment as they move forward, and women that will be diagnosed in months and years to come?
Well, I think one thing patients can expect to see is, now that we know that the 2-drug regimen is as good as the 3-drug regimen, we know that we couldn't really add any targeted therapies or biologic therapies to the 3-drug regimen. However, we can and have already started doing is adding targeted therapies, and we just completed a study, 86P, that did that, adding these targeted therapies to the carboplatin and paclitaxel, because we think the future is in trying to more personalize therapy to each cancer patient. But we're still at the very beginning of that science.
Thank you very much, Dr. Miller. Thank you for your time, and thank you for your commitment to women's health.
You're very welcome. My pleasure.